It is now time for me to acknowledge the traditional owners of the land on which all of us are participating in today's world's largest overdose prevention training. Obviously, we are scattered all over the southeastern corner of Australia, so I can't just refer to the Wurundjeri and others of the Kulin Nation where I am. So I pay my respects to elders past and present wherever you may be in any part of Melbourne, rural and regional Victoria, and indeed in New South Wales. And I acknowledge also emerging leaders in those wonderful cultures, also affected by the stuff we're talking about today, just like we all are. I'm going to breathe for a moment, look at my notes. Okay. International Overdose Awareness Day was created by Sally, or SJ Finn, in Melbourne 20 years ago. This Monday is the 20th anniversary. Today, International Overdose Awareness Day is a global campaign. And last year, for instance, there were 874 events like this one. I mean, none as cool as this one, let's face it. But, you know, other pretty cool things going on, which took place in 39 countries. Since 2012, the project has been run by the Pennington Institute, and we'll hear from Lily Owen today from Pennington. But before that, we are going to hear from that very founder, Sally S.J. Finn, in a lovely video that she's prepared for just this occasion. Thanks, Del.
Hi there, my name is S.J. Finn, or Sally J. Finn, and I'm the founder of International Overdose Awareness Day. I'd like to begin by acknowledging that I'm speaking from unceded land of the Yaluk Willem clan of the Bunurong people. And I would also like to acknowledge that this is great that First Step are putting on the world's largest overdose prevention training yet again. It's fantastic for the day and, of course, for all of us here that are listening. It is because it has been the 20th anniversary this year. I've been looking back to when things first began, and for me personally, it was even a very impacting incident that occurred in 1983 when I was a young family therapist in rural Victoria in Bensdale in the east of the state, in which a woman came to see me. Her son, his name was Nick, had passed away from an overdose, and she was devastated by this, of course, but also devastated by the fact that while the town grappled with the news of this drug death, she had to sort her feelings out very much alone, and the isolation that occurred in her grief never left me, really. Nick had gone to see two friends on a typical afternoon, and they'd been drinking beer and, of course, had a shot of heroin together. And when Nick couldn't be roused by his friends, they did try to resuscitate him. They called for an ambulance, but the ambulance, the only one in town, was at an accident quite a way away, and so it took 40 minutes for ambulance officers to arrive. They also worked tirelessly on Nick, but were unsuccessful in reviving him. So this year, because Pennington have been running the event for the last 8 years, I've been able to sort of reflect on my feelings about the day, and I've been writing a poem that's been every year that's been read out on occasion, and I would like to share this year's poem with you. It's called Folding to a Line of Breakers. They said there was some other force drawing you closer and bending your will, as if a momentary thing has no power. The build-up led to the unknitting of everything, brought me back to my focus, to the craft and sound of your smile. We were further along the same coast when an accident drew the only emergency vehicle in the wrong direction. So many things churning to make a mountain-high barrier impenetrable, the seconds ticking and your thoughts being taken to sow new seed among the grass. I travelled to you, knowing what to do, even though explaining it was beyond me, so that now I have you embedded in each blink, in each fragment, in each bridge to life's momentum. Thank you very much.
It's so great to hear from Sally, who certainly, as if we needed any reminding, but she does nonetheless remind us of the gravity of the moment. I want to mention at this point that obviously there is some heaviness to what we're addressing today. And I want each of us here to make a little promise just to ourselves that if we are feeling in any way shaky at the end of this session, call a friend. Just call someone. Don't even have to tell them what you've been doing. Just give mum a buzz. Bang on the fence and have a chat with your neighbour. Don't finish the session today feeling alone. You will have come from a great community, all of us here today, and try and extend that past the end and have a bit of a chat to someone. I remind people that the number for Lifeline is 131114, and no one should hesitate for a second to call that number whenever they're feeling that they may be at risk themselves. 131114. We move on, however, from that feeling of great seriousness and remembering those that we've lost to focusing now on hope and empowerment. We're here today because we are not despairing. I had a fabulous quote from US politics just recently. Despair is an insult to the imagination. So we've used our imaginations today. We've gone online with this forum. Some scientists a while ago used their imagination. They came up with an extraordinary drug, naloxone, capable of reversing overdoses. So our job now is to learn about how to use it, where to get it, make sure we remain mindful of those facts, and to continue to feel that very strong sense of community. I'll be handing over in just a minute to Lily from Pennington, who's going to talk about what is overdose, what are opioids, about harm reduction, about stigma, about risk factors. She's going to hand over to Q from Windana, who's going to do a live demonstration of using the two main methods for reversing overdose, the Pronoxad injections and the Nixoid nasal spray. And there are two wonderful pieces of news for you all. Firstly, there's going to be a quiz at the end. So I'm sure you're all like super keen. The other piece of news is we will be putting up during these presentations quite a few links. We're going to send everyone who signed up an information pack. It won't have the entire slideshow, but rest assured you'll have the basics arriving in your inbox, as well as a survey. Please do fill that in. Let us know what you made of the day. And of course, you can go to Pennington's website and First Steps website and a number of other websites and get a lot of information. One thing that is coming is a list of where to get naloxone in your local community. You might want to pay special attention there, but we'll be sending that information through as well. Reminder, Q&A. If you have any questions, please write them down. If I feel that I should interject during the presentation to ask the guys the questions, I will do so. Otherwise, we will save them for the end. I shall stop rambling at this point and hand over. Are you ready, Lily? She's not ready. Let's try again.
Yes,
are you ready, Lily?
I am ready.
Fantastic.
Thanks so much for the intro.
You have the reins.
Information. Hi, everyone. Thank you so much for being here for International Overdose Awareness Day. I feel really lucky to be here working, in the harm reduction space. I sort of started 3 days before COVID, and it's amazing to be here for my first ever International Overdose Awareness Day, adapting to all of this new technology. And it's so good that everyone's here on a Monday night, and yeah, I feel very lucky. Today's been a bit of quite a reflective day. I feel very lucky to not only be sitting here, but actually be alive, because I myself experienced a non-fatal overdose a few years ago. So, I've lost a few friends to overdose and still have friends out there using. So I you know, addiction really does hit everyone's rooftop. So very lucky to be here, and just going to start by talking about opioid drugs. So the reason why we're going through opioids is that, you know, there are a few different types of overdoses. There's stimulant overdose, polydrug overdose, and also sedative overdose. And we're going to be going through opioids in relation to the single drug use and also in terms of polydrug use. So in Australia every day, there are 3 deaths related to opioids. There are 150 hospital admissions, and there are 14 emergency department admissions. So opioids are a family of drugs that depress the body. So they depress the signals from the central nervous system, from the brain to the body, and they reduce pain signals. So that results in the person feeling sleepy, euphoric and relaxed, which is, you know, the underpinning reason why people use opioids. So opioids, no matter how they're obtained, they carry or taken, they carry risks of dependency and overdose. So most opioids are actually obtained for pharmaceutical use. And 70% of all opioid deaths are actually related to pharmaceutical drugs. So say oxycodone, tramadol, morphine, codeine, fentanyl. So that's a huge amount, and prescriptions have really risen in Australia. So in 2008, there were 10 million prescriptions for opioids for medical use. And in 2018, there were 14 million, which is a really large increase. So someone can become dependent within just 2 days, and that's, you know, a body starts functioning with the type of opioid in their body. And if it's and they're going to have to start, your body's going to get used to it, and you're going to have to start taking more and more just to sort of feel that base level. Yeah, it carries you know, a lot of dependency. And also to mention that drug use is always with, you know, it can have polydrug use as well. So that's the mixing of depressant with depressant, or a depressant with stimulant. So say you mix alcohol and benzos, which is another sedative, and then mixing opioids as well. So that's a depressant on a depressant on a depressant. And it's not like 1 + 1 + 1 = 3. It's, you know, there's a stacking effect. So it's 1 + 1 + 1 = 100 effects. So when mixing opioids, if you mix it with other depressants, it can be very dangerous. So now I'm going to go through who's most at risk of an overdose. So people who inject drugs. So you're going to, when you inject opioids, you're going to get your drugs harder and faster. So it's also people who use drugs in general most at risk. People who have had some time off and their dependency has reduced. So it can be as simple as 2 days off, as I mentioned before. It can be someone, you know, you go through rehab. That's how I've lost a lot of friends, of people who try to get clean and their dependency has reduced a dramatic amount, and then they take the same amount that they used to. So that could be detox, going in for a medical procedure. You know, also with COVID, you might not be able to get your supply as easily because of curfew, or because supply, you know, has decreased, things like that. Patient history. If someone has overdosed in their lifetime, the risk of overdose has increased dramatically because they have put damage on their, they've damaged their brain or their internal organs. Also other medications, if they're co-prescribed benzos, other sedatives, antidepressants, antipsychotics, the increase of overdose is up. So also people who are newly released from jail. So in 2017 in Victoria, 7 out of 10 people who died from heroin overdoses were actually recently released from jail. Also, again, it doesn't, you know, overdose does not discriminate. So it can be anyone who's prescribed opioids at all. So it could be, you know, the little old lady who's prescribed tramadol for her pain. She may have forgotten that she's taken it in the morning and she's taken another dose. You know, mix that with another medication, boom. It's, you know, it's a very common thing when it's, especially for large quantities of pain management. So harm reduction is actually a movement. It's for social justice, and it's built on the belief in and the respect for the rights of people who use drugs. Underpinning this is a non-judgmental approach. So it's really about seeing people who use drugs as, you know, from this humanistic point of view. You know, what are the values that are underpinning your interaction with people who use drugs? It's fundamentally about enhancing a client's quality of life. So whether it be, you know, no matter who you are sitting here today, if it's someone you see walking down the street, or if it's, you know, someone that you're working with, someone, you know, you're an AOD worker, whatever it is, it might just be as simple as a smile. It might be looking someone in the eyes. Just having that core empathy and that understanding, that can be enhancing a client's quality of life. Or it might be about passing people on to other services, looking after people's health, other comorbidities. There's, you know, a range of things that we can do to enhance a client's quality of life. You know, there's under harm reduction, there's needle and syringe programs that are providing clean injecting equipment and education for people who use drugs. It's really about empowering those who use drugs to be the primary agents in reducing the harms of their drug use. So, you know, providing that information and meeting the person who uses drugs where they're at. Behaviour change is an incremental process, and it's multifaceted. You know, drug use is multifaceted. There can be, you know, it's not a complete spectrum. There can be someone who's completely abstinent or someone using drugs in a really harmful manner. And it's understanding that that person can only be ready where they're at. You know, there's no fast trick. There's no one size fits all recovery. There's no one size fits all approach to sort of dealing with anyone. There's so many complex social factors that influence the drug use and influence the vulnerability to the drug associated harms. So it's very closely linked that poverty and trauma and discrimination are linked to drug use. And it's really about understanding that it's someone's love. You know, today on the 31st of August, it's most important to remember this message and to pass this message on to society. There's this huge problem with stigma. There's this huge problem in the media. There's a huge problem even with my friends. You know, they know that I you know, they're beautiful people, but I still hear the most ridiculous things come out of their mouth about people who are struggling with drug addiction and mental health problems. There's a real sort of lack of understanding and a lack of empathy that sometimes can come through, and that's just through you know, their own filter. We all have our own filter. We're born with a very clean slate, but through influences, we have these values that are created, and unintentional personal bias can really come across to the client. So it is really important to see the client, not the drug, and also to understand that language is so powerful, and that can really trickle down to your, you know, to children, to grandchildren, and it can be generational. So if we can witness our values and witness the way that we're speaking, we can then undo that entrenched stigma. We can then, you know, create a more loving environment and a more loving perspective as well towards people who use drugs. You know, when I was born, and, you know, when I went to school and everyone else who uses drugs, when they're little kids in kindy, you know, I wanted to be a ballerina. I didn't want to be a drug addict. I didn't want to be, you know, faced with all of the, you know, complexities that I was, you know, faced with while I was using drugs. I didn't want the mental health problems. I didn't want the anxiety. I didn't want any of that, but it is part of, like, you know, the human condition. So it's about understanding that, you know, people don't want to be in addiction. People want to get better, you know, and then the reason why maybe people don't want to get better and this is just from my own perspective, is that they don't know where to go to get better. They don't know who to turn to. They don't know, you know, there's so much shame that they lie to others because they're lying to themselves. So really important to have that empathy, and really important to understand what your values are, just to witness them. And, you know, if you're working in the field, now's a really good time to sort of, especially with COVID, self-care is such an important place to be, you know, to really tune into yourself and just to sort of, you know, journal and witness the way that you might be unintentionally, you know, putting your own personal bias onto clients or just in general. So it is that reflection, and it's really important to reflect anyway when working in this field, or if you're dealing with, you know, lovers, partners, children, you know, or parents that also are dealing with using drugs. So jumping through to why naloxone is so important during COVID. So firstly, we did at Pennington Institute, we did a bit of a survey with needle and syringe programs, and also to more of a general public in through social media and Facebook and things like that. There were a few takeaways, and what we really did find, and this is through a few other surveys in Australia, was that there has been a real change in drug supply. So there have been also, so that means that there's riskier drug taking habits. What I mean by that is that there's, you know, drugs have been cut with other stronger drugs. There's been anecdotal reports also that heroin's been cut with fentanyl, which is 100 times stronger than morphine. There's also many drugs that have been coming through sort of the black market through online. They come in the mail. It's more accessible. When you can't meet with your dealer, you can jump online and get it this way. Also, they have, you know, a different molecular makeup. So there's, you know, a little something, tiny difference. Therefore, it doesn't get, you know, there's more chance of it getting through the mail without it being sniffed out by the dogs. So that's, you know, coming from the Middle East and China, and it's really, really strong opioids. Also, people are more anxious, and people are more isolated, people are more alone. So not only is that dangerous for unintentional overdoses, but it also creates it's that opposite thing to recovery and to happiness. Like, you know, isolation feeds the addictive tendencies and the drug using. So also there's patients are prescribed opioids for pain management, so people will be stockpiling their medicines in fear of supply issues. And also there's more access to takeaway doses for opioid agonist treatment. So passing on to Q2, who's going to run through naloxone and demonstrations for the prenoxide and the Nixoid.
Thank you, Lily. Thank you, Patrick. Hi, I'm Q. I'm the harm reduction practitioner at Windana. It's a detox and rehab based off in St. Kilda. I also work at the North Richmond injecting rooms, so have seen a lot of overdose and dealt with a lot of overdoses. So let's jump right into naloxone. All right, so what is naloxone? It's a temporary reversal agent, and I just wanted to highlight that it's temporary, and I'll tell you why that's really important to know once we get through, okay? There's a couple of numbers I want you to remember at the end, because it's very pertinent to how we use naloxone and are aware of the aftercare, and I'll tell you about that as well in just a bit. Also, when we approach naloxone, I want you to think about before we give naloxone, when we do give naloxone, and then after naloxone. That's how I categorize that, okay? So yeah, so before naloxone, when we give naloxone, and after naloxone. All right, so how does naloxone come? What is its shape and form? The first one is the ampule, as you can see on the slide. It's a glass ampule, like a glass vial. It has 400 micrograms in it, and it's really old school. I've used the ampules many times, still don't like it. Hate breaking glass, okay? Very scared of it, still. It's very old school because it's fiddly. When we have an overdose, we want to cut down that time about fiddling around with equipment and give the injection, right? So that's sort of being phased out. It's still available, but we try to go for the other two formulations, which are much better and much more streamlined. So there in the yellow box and in front of that is a pre-filled syringe. That's what it's called, because it's already filled, and it's filled with 5 doses. In the ampule, you only get 1 dose at a time, right? But in the Prenoxad, the pre-filled syringe, you get 5 doses right off the bat, okay? And I'll show you how to use that in just a bit. The Nixoid is the new kid on the block. It's awesome, it's sexy, it's an intranasal spray, okay? And it's got, as you can see on the Nixoid, like the yellow bit, sorry, the orange bit there, it says 1.8 milligrams. Sounds like a lot, but you only get half, okay? You only get half because the nose bioavailability is what it means is how much drug you get into the body actually is half, all right, about half. So you get only half of that, all right? You still get a little bit more than the intramuscular injections, which is the ampule and the Prenoxad, but the Nixoid is that, okay? And it's really good because people don't want to use needles and sharps and stuff like that. If you had like an elderly grandma or grandpa, you know, that are using lots of opioids and had a history of overdose, not particularly a drug user per se, that could be a good one. And if you're a family member or community member and you don't want to use the needles, that's a really good option for you, okay? Cool, next slide. All right, so how does naloxone actually work, right? So what it does is it kicks opioid off the receptor. As you can see, that white platform there, and it's got the opioid drug on it, turning on the receptor to turn off your brain, okay? It's really weird, all right? It turns on the off button, okay? So what naloxone does is it kicks off the opioid. It doesn't flush out the opioid, okay? It's very important to know. The opioid's all there still, all right? It doesn't get rid of anything. It just competes for the binding site, all right? Fantastic, great. All right, so before we dive into sort of overdose awareness in terms of like when you overdose from an opioid, I just want you to know that it's actually quite hard to recognize an actual overdose, all right? Why it is hard is because you need to see a combination of different things, but in the end, I'll show you how to get it right, okay? You just get a response, all right? So don't worry about memorizing all of these. In the end, you have to ask or elicit a response. So we'll talk about that in just a bit. And before you dive into giving naloxone, you gotta see if the person's actually overdosed, right? And you have 4 minutes to do that. Why does it take 4 minutes? Why do you have 4 minutes? Is because it takes about 4 minutes for brain hypoxic injury to set in. Meaning if you're not breathing, there's a lack of oxygen going to the brain, which is overdose. You have 4 minutes to respond. And that's a quite amount of time, all right? In the panic of the moment, it'll seem like a crazy frenzy of chaos, but you have 4 minutes, take a deep breath, or even 3, and then approach it, okay? So here we go, all right. So what are some of the signs and symptoms of opioid overdose, all right? So there's no response to a stimulus. And what that means is either voice, like, hey, Patrick, wake up, right? Or you will squeeze the crap out of the shoulders. And I'll tell you why, okay? It's called pain stimulus, all right? It's a very good sign or a very good way of showing if the person's actually really, really sedated, all right? Cannot be woken up, all right? And snoring or gurgling noises, okay? And it can be snoring and gurgling noises, not actually all no breath because the airway has collapsed, all right? And that's sometimes it's quite a common sign, especially the larger male with a small airway, all right? So they can be irregular or shallow breathing. And when it's not an effective breath, which is irregular or shallow breathing, it basically means there's no breath, all right? So that's a very important thing to know. There's not an adequate breathing and not enough oxygenation. So no breathing at all, of course, and meaning there's no rise and fall of the chest, all right? So blue lips, because there's not enough oxygen going to the face, all right, as well. And ashen look if you have a darker skin, all right? Limp body or heavy on the nod. So heavy on the nod meaning there's a lot of sedation and the body positioning is very off, not normal, right? Okay, and that can be very hard to see. So for someone who's on a comfy chair, in a car or on the street falling down, all right? Okay, oh, wrong way, yep. And possibly vomiting, okay? Possibly vomiting is not a sign of an overdose per se, but just something to watch out for, because you don't want that person to breathe in the vomit, which is called aspiration. That can be quite lethal in the long term. Can be treated, but also very annoying, or something you can avoid, okay, by doing something just a bit. And make sure you don't take the approach just to let someone sleep it off, all right? You never know if the person has overdosed or is just intoxicated, all right? And that there's a way to approach that. So again, very difficult to recognize an overdose, but I'll show you how to do that, all right? Okay, next slide. So this is just a pictorial diagram of what we just talked about. So no response, slow, no breathing, making gurgling or choking sounds or snoring sounds, blue lips, and cold clammy skin is the other extra one. The sixth one there was pinpoint pupils, but I just want you to know, we never assess for pinpoint pupils. It's very difficult to assess that. Depending on different types of lighting, you have, your pupils will dilate or contract accordingly. And if you mix drugs, it can also have that effect, whether it's dilated or pinpoint, okay? Great. All right, so what do you actually do? All right, so you stay with the person, obviously. Before you act, check for danger, because we always will follow the first aid protocol, Dr. SABC. That will never change, okay? So doctor and then DR, so D for danger. So check for needles, okay? If there's needles on the floor, if there's a pipe or anything like that, or broken glass or a knife or anything like that, get rid of that. And if the needle is still in situ, meaning it's still in the site where the person has injected, whether it be the arm, whether it be the neck, whether it be the groin, make sure you take that out and apply pressure, okay? All right? But before you do that, you'll actually check for a response, okay? It's a bit weird. This is a little bit different from just the normal Dr. SABC, okay? So when you get the response, you call out, hey, Patrick, wake up. Hey, Lily, wake up, right? And if you don't get any voice response, you go for a pain response, okay? And you squeeze the crap out of the shoulder here, okay? Very painful if you do that. I'm just doing it on myself lightly and it's already hurting, okay? So go for that. We don't do the whole chest rub anymore. We just go for something simple, all right? And it's just as effective. If there's no response from the pain stimulus, really hard squeeze, that's a very good sign he's not responding to pain. It's a very good sign that the person has overdosed, okay? So administer naloxone straight away, then call for help, or simultaneously, okay? You can always ask Siri to call 000 or call 000 quickly and get the naloxone ready at the same time, all right? Give the 000 operator the correct information they ask for. If you say it's a heart attack, they won't come any faster, okay? If you tell them it's an overdose, they'll come prepared for an overdose. Very important to know that. Okay, so if the person breathes again after administering naloxone, you put them in the recovery position, or if the person throws up, okay? And the recovery position is very easy to do, all right? If you haven't done first aid, please do first aid. And if you don't know what the recovery position is, get online on YouTube and check it out. Very, very fancy way of rolling someone onto their side, all right? Okay. And you can administer naloxone every 2 to 3 minutes. Very important number to note down if you're taking notes, something to remember. A lot of clients who I've trained forgets this number too, okay? You can administer naloxone every 2 to 3 minutes, okay? And what's the max? There is no max. You're trying to get the person to breathe again. You cannot overdose on naloxone. If you're pregnant, you have to administer naloxone every 4 minutes, okay? And I'll tell you why that is a bit, okay? So it's just a little bit of a different thing in terms of not harming the baby. It's because of naloxone being in a different category, different categories for how safe it is in pregnancy, okay? But otherwise, every 4 minutes for if you're pregnant, all right? Okay. So a really awesome thing is there's virtually no side effects with naloxone, okay? Very insignificant side effects, okay? There's no recorded cases of allergy or anaphylactic reaction to naloxone in Australia at all right? And you cannot overdose from naloxone, okay? All right, and sometimes on the streets, Narcan or naloxone has a bad rep because it will take away the effects and stuff like that. In an overdose, very important to know that you're trying to get the person to breathe, okay? That's the key. All right, great, okay. Oh yes, and when you're trying to elicit pain, don't slap the person, just squeeze. the trapezius, all right? Okay, cool. If there is clothes, if there is, you know, you're wearing jeans or a hoodie, you can go through the clothes, okay, when you're injecting, okay? You don't have to remove anything. You don't have to swab them. Infection control is secondary, okay? Breathing is pertinent. Breathing is the most important thing, all right? And this is the recovery position, as you can see, all right? So we'll go through that. Sorry, you can go through that yourselves. All right. So after you give naloxone and the person has come to, stay with the person until the ambulance arrives. You inform the responder of how many times you've given the naloxone and when the person was first overdosed, okay? When you notice that. Very important to note that. So, and another thing, a very important number to remember is naloxone lasts in the body for 30 to 90 minutes, okay? It usually only lasts about 30 to up to an hour. 90 minutes is stretching it. So you just have to know it's temporary, all right? It will get out of the system very quickly, all right? So you have to stick with them for at least 2 hours, especially if you're in the suburbs, if you're in rural region of Victoria, you know everybody. The person who's overdosed doesn't want the ambulance to come and he wants to change sites, as in relocate somewhere else or cancel the ambulance. Make sure you stick with them, okay? No opioid has left the system, all right? So they can drop again, they can overdose again. For example, like tramadol, sustained release, lasts in the body for 12 hours. Oxycontin, 8 to 12 hours, right? You know, so naloxone, 30 minutes, okay? 30 to an hour, all right? It is important to seek medical assistance after giving naloxone if the person survives, because it is, you don't know if they have an underlying health issue that we need to resolve as well. For example, like lung disease, emphysema, diabetes, heart condition, or something like that, okay? Or because from the overdose, it could have impacted their underlying health. So very important to get a health checkup, okay? All right, so once you've used prenoxid, it's important to never recap the needle, all right? Just put it back in the container it comes in, all right? And you can give it into a pharmacy or an NSP, okay? If it's Nixoid, chuck it in the bin. All good, all right. So aftercare, just a couple of points to remember. Risk of dropping again, because opioids last for a long time in the body. Naloxone does not flush it out. Make sure you do not use on top again, because if you have given multiple doses of naloxone, you can feel a little bit of a withdrawal syndrome, okay? Because it's blocking the opioids from working. So make sure you don't dose again. Stay with them for at least 2 hours, all right? Make sure they get some sort of a checkup, all right? And if you've used naloxone, make sure you get another one. And so how do we get naloxone? How do we access it, okay? There's something called a Naloxone Subsidy. Basically, these places on the list there, you can get it for free. That's a really good thing, because uptake of getting naloxone, meaning, let's just say I got Patrick, go to your doctor, get a script, and go to the pharmacy to get naloxone. That uptake is very, very low. Reason why? Unfortunately, due to discrimination and stigma, okay? A lot of people don't want their local GP, the local pharmacy, to know they're a drug user due to stigma and discrimination. That uptake is very, very low. And that's why these naloxone subsidies exist, okay? You get them for free. If you're in a little bit of a pickle and you need to get it right away and you have a near pharmacy, in Melbourne CBD or most of Melbourne suburbs, you can get it for about $40. Prenoxid's about $40. Nixoid is about $46.80 without a script. There's Schedule 3 medication. You can get it over the counter, just like your Phenergan or, you know, let's just say like Anagrain for your migraine, right? You can ask a pharmacist and you can get it over the counter for a full price. It used to be $80, now it's dropped, so that's awesome, all right? You can get it on script, and they'll be like $36, $38, so not much difference in terms with the full price now, which is good. But if you have a concession card, you'll get it on PBS, all right? But again, free on the list there, all right? So get yourself one. Everyone should have their own one, okay? Great. All right, so how do we even prevent an overdose in the first place, right? So you don't want to mix. Lily, I was talking about, you know, polysedative overdose before, meaning multiple sedatives used on top of each other, where you can mix alcohol, benzodiazepine, like, you know, Xanax or temazepam, or Valium, or Rivies, or Rivitrol, which is clonazepam, many different benzos out there, right? So basically sleeping tablet, alcohol, an opioid, if the unit of its sedation was 1 and alcohol was 1 and opioid was 1, if you add them together in pharmacology, there's a phenomenon called synergy. You get a 100-fold increase, not like a unit of 3, okay? That's why you get a polydrug overdose, and that's why they are so deadly, even if you're using small amounts of each one, all right? Methadone is mentioned just separately because methadone is special in the way that its half-life is really, really long. The half-life of methadone is about 5 days. So you get half the dose of methadone still in the body for 5 days. Methadone is not evil. It's not a bad thing. It's just something to know that the half-life is long, okay? All right. Methadone can help you gain the tolerance, stop you from withdrawing, and use less heroin on top or whatever opioid using on top. So don't discard that as something bad here. It's just to note that the half-life is long, okay? And Suboxone, again, is special as well because it has a blocking power, okay? It's a special one, again, because it's a partial agonist, meaning what it will do is it will give you the effects of opioids, but it also block other opioids from working, okay? And you may use quite a bit on top to get the effect that you used to get. So again, watch out using on top of Suboxone. If you have short breaks, or if you're using from a new batch, make sure you start low and go slow, especially during COVID, because of the change in supply, change in your batches, makes you have a taster, okay? And if you've gone without, if you haven't used for more than 3 days, your tolerance will have dropped already. So make sure you start low and go slow, all right? Make sure you use with another person, okay? This is essential to harm reduction. You can't treat your own overdose. You have to have someone there with you. The person needs to know that you have naloxone on you and how to use naloxone, all right? So once I train you today, you will be able to train someone else. All right, great. All right, you can try smoking it because you can't smoke the amount you inject sometimes, okay? You'll burn your throat, you'll get bad cough, right? It'll be unpleasant. You can shaft, which is putting up your butt. Sounds weird, but it's actually very vascular there, meaning there's a lot of blood supply, all right? When you're in your mom's wound, the first hole that is produced in the body is actually your anus, which is funny, isn't it? There's 2 different types of mammals. We won't go into that. You can put the the syringe into your butt and you can put it in there, okay? It's called shafting. It's actually more for vein care, but you can overdose by smoking. You can overdose from shafting as well. It's just another option than injecting, okay? Look after your health. Make sure you look after your physical health and mental health, all right? It will help you reduce your overdose, okay? Just do the basics first. Fantastic. Great. All right, let's do the live demonstration. Let's get into it. Let's do some fun. Okay, so let's just say Patrick has overdosed. He is a known user of methamphetamine and he has a pipe next to him, right? You don't know if he's popped some OxyContin, so you have to give naloxone. You can give naloxone basically anything, all right, in any sort of situation in terms of an overdose. Patrick is missing an arm and a leg. He's got brain cancer. He's got type 1 diabetes as well. Can you give naloxone? You still can, okay? There's no contraindication there, all right? So you need naloxone on your person, right? So here it is, my bag here, and I have naloxone. Fantastic. You have to have naloxone on you to be able to use it. So have it on your person. Fantastic.
Q, it's Patrick here. I'm going to jump in for just a sec.
Sure.
Can we make sure we've got the slideshow down? And you should have, everyone should have Q now really big on your screen. Just a big smile. Oh, I didn't realize he was so handsome. Look at that. We want to get in really close, see the equipment he's using. So in the top right-hand corner where it says gallery view or speaker view, make sure you click that until you get a great big picture of Q.
Cool. All right. You can see my big face. Okay, fantastic. Everyone ready? All right, let's do this. Okay, so Patrick's overdosed. He's got a meth pipe on the side. He's like, he only uses meth. I'm not going to use naloxone. Wrong. You're going to use naloxone, okay? You don't know, all right? Fantastic. So this is my prenoxid. We're going to go through prenoxid first, all right? So usually prenoxid comes in a little pack like this. It's got a little tic-tac like plastic strip there. It's the first level boss, I call it. You have to get rid of it, all right? I like to keep my prenoxid ready to go like this. Get rid of that plastic wrap you get, okay? That shiny little wrap there, all right? You just have to peel that red little thing off, okay? Then you get something like this. And now, it's not a fountain pen, it's not a fancy fountain pen, so you don't open it like that. Make sure you crack it open, all right? Whichever way, crack it open, all right? And then, voila, that's the prenoxid there, okay? And this is a second level boss, the distractor. Check this out. It's the information pack. I've given you the information. You're ready to go, all right? Okay. Third level boss is the safety cap. Make sure you get rid of that baby here. Twist it open, and you're ready to go. As you can see there, there's 5 doses to go, all right? The little triangles there, all right? So before you give this, you need to put the needle on, all right? And you'll get 2 needles inside the pack like this, okay? All right, so you're gonna peel it off like a pro, like this, and you're gonna twist it on, all right? Twist it on tight, okay? Get rid of the pack. And when you open this, make sure you don't hesitate when you pull this open, okay? I've seen a few clients even hesitate, like jerk backwards when it's open. Just go out in one smooth way, all right? Boom, done, and you're ready to go. This is an intramuscular injection. You're not gonna put it into a vein, you're not gonna put it into an artery, you're not gonna put it anywhere else but into a muscle. And where? You're gonna put it into the big muscle groups. So the deltoids, or the shoulders there on the side, and on your thighs, okay? Side of the thighs, front of the thighs. Don't go for the inner thighs. That's just mean, okay? There's not much muscle there, and it'll hurt like very bad, okay? Hurt very bad. Okay, and you're not gonna hold the naloxone like in Hollywood, all right? And you're not gonna stab it into the chest like in Pulp Fiction, all right? You're gonna into the shoulder or the thigh, okay? And you can go through close, don't forget that. And when you do give a dose, that black plunger there, as you can see, the start of that plunger there should go to the first tip of the triangle there, okay? And you'll notice that the plunger is actually further back than the actual start of number 1. That's because there's an air bubble there. You don't need to get rid of that air bubble. Every little drop here is precious naloxone, so make sure you don't do the whole Hollywood thing where you flick it, and make sure there's no air bubbles. Don't worry about that at all right? And if the person's really skinny and you're gonna be worried about hitting bone, don't worry about it. Go all the way through, okay? So when we do inject, I'll show you on my Kleenex box. This is Patrick's thigh. I'm gonna go right through it on top of Patrick's thigh. He's on a very awkward position, and he's in his car, all right? He's got the crack pipe there. There's no needles, there's no signs of using opioids. I've tried to get, I try to call out his name. I've squeezed the crap out of his trapezius. I've called for 000, all right? But there's no response, right? So I'm gonna give naloxone, put it into his thigh, through his clothes, and I'm gonna inject the first dose, okay? There, and that should be 1, okay? Now that you've given it, you can leave it in there if you like, this is preference, or you can take it out, okay? Up to you, doesn't matter. And how often can you give it? You can give it every 2 to 3 minutes until you get a response, until he breathes again, okay? Very important to note, all right? By accident, if you're in a very, very anxious and you're very worried about him and you accidentally give the whole 5 doses, all right? Very rarely happens. I don't think I've known anybody who's done that, but accidentally you give all 5 doses. Will Patrick overdose from it? No, he won't. Will he feel a lot of withdrawal from that? Hell yes. All right, so make sure you know that, okay? Great. All right, and then you can inject it again, all right? Different spot or same spot if your aim is perfect, and you can give the second dose, okay? Did I get the second dose? There, perfect, all right? And you can twist it while you're there, all right? Once you put it in and you're like, oh crap, I can't see the dosing, right? You can twist it and have a look at it, all right? Whichever position you're in, all right? It should be 90 degrees, okay? It should be 90 degrees into the front of the thigh, side of the thigh, or the deltoid. So it'll look like this, okay, in there, like that, okay? Cool, fantastic. And if it's into the thigh, the side, like this, or in the front of the thigh, like that, 90 degrees, okay, to the plane. Fantastic, all right. And then you've done that, you're gonna put it back into the case. You're not gonna recap it, and you're gonna close it, give it into a pharmacy or the nearest NSP. Fantastic. How often can you give it again? Every 2 to 3 minutes. If you're not pregnant, every 4 minutes if you're pregnant. Okay, fantastic. All right, let's just say I don't like needles and I get myself some cool Nixoid. This is the coolest stuff, all right? Nixoid there, cool. All right, okay? You're gonna get it in a pack like this. Okay, this is the Nixoid pack, all right? And you're gonna get 2 nasal sprays inside, all right? So there should be 2 nasal sprays inside. What does it look like? It just looks like this. Cool, ready to go, right? So you can get rid of the box if you like. What you're gonna do is you're gonna peel it. Voila, you got Nixoid there. Pull it out. And if Patrick's on the floor, great. If he's not, you just have to tilt his head back in the car because he's in the car, right? And what you're gonna do is you're gonna hold it like this. I don't want you to hold it like this. I don't want you to get trigger friendly like this. Why? It's a little bit inappropriate, but I don't want you to blow your load before you put it into the nose, okay? You gotta keep that there. Very precious stuff, because once you press it, it's all gone, all right? And you don't want to do that, right? You only got 2 shots. So make sure the person's head is tilted backwards. If he's in the car sitting down like this, he's like this. You're gonna tilt his head backwards and you're gonna put it into the nose, then press the button, okay? Make sure you don't, the trigger's a little bit weird. Don't get too chaotic, so make sure you hold it onto the side like that, into the nose, then you can press the button. Cool, and that's it. Again, that's 1.8 milligrams, but you only get half of that, all right? So it's not a crazy amount of dose. Higher than the one in the prenoxid. Each dose is 400 micrograms in the prenoxid. Here, it's about 900, 600 micrograms that you get through the nose, okay? Cool. All right, and what do you do with this after you've done it? Chuck it in the bin. All good. All right. How long does naloxone last in the body for? 30 to 90 minutes. Very important to note that, okay? All right. Great, so what Lily's showing you here is just some pictorial diagrams just to refresh your memory. Crack it open, get rid of the safety cap, put the needle on tight, hold it like a pen, put it into the muscle at a 90-degree angle through close. If the person's got armor on, if the person's got like Kevlar or body armor on, make sure you take that off, okay? All right, next slide. Okay, and just that again, fantastic. The Nixoid, very easy. Peel it, tilt the head backwards, and put it into the nose, okay? The only thing I can think about when you cannot use the Nixoid is in facial trauma. If the person's face is being bashed in, you cannot use the Nixoid, okay? Especially because there might be bone wriggling around, all right? That's the only downside to Nixoid. Very uncommon, can happen in the streets. That's why Nixoid is maybe preferable maybe because of that. But Nixoid is still a very good option, okay? Next slide. Fantastic. Don't hold it like that, all right? Don't want to hold it like that. Don't want to blow the load before you enter the nose. Fantastic. Okay, next slide. Storage, very important to know. Naloxone does not like the heat, does not like the sun. Keep it out of the sun, keep it in a dry, cool place. Do not keep it in your fridge. Unless you're in like rural, regional Victoria and super hot, all right? Just to watch that, okay, when the summer's coming, okay? And disposal, obviously, don't recap needles, put it in the box, give it into your pharmacy or NSP, make sure you discard Nixoid just in the bin. All good, fantastic.
Stu, I'm going to jump in. Before we get to the quiz, everyone will be super keen. We have some questions that are very, very specific about what you've just been looking at. One of the questions relates to whether or not we give another dose. So whether it's Penoxad or Nixoid, if the person comes to, starts talking, starts breathing regularly, what are the signs we're going to look for? They're going to make us decide, okay, we don't need another dose at the moment.
Look, if they're open their eyes and they're talking to you and they're able to breathe at a normal way, and they haven't fallen back asleep again, right? That's a really good sign you don't have to give naloxone, okay? So once you give naloxone, a really good sign when they come to is they'll open their eyes, right? And they'll breathe again, okay? That's a really good sign, all right? They haven't fallen back asleep. If they do fall back asleep, you're doing the same thing again. Hey, Patrick, and you're gonna try to get a voice, right? And you're gonna try and squeeze the traps again if you don't get any voice response, okay? Same thing. But when they come to, they'll open their eyes, they'll wake up, they're able to stand up or sit up and talk to you, okay? That's a very important thing to note. They can be very overly sedated in especially polydrug use. If they use like tons of Lyrica, tons of benzos and you've taken that opioid effect away, they can be quite sedated and they can be sleeping, but you will know that they're breathing quite normally again, okay? They're quite normal. The color is good, okay? And when you squeeze their traps here, they'll shrug, but they won't go real blue or stiff on you, okay? That's really important to note that, all right? Because we're in the climate of polydrug overdose, it's also important to note you can get the odd friend or a client that has overdosed and is quite sedated even after giving naloxone, and they've known to use opioids, benzos, Lyrica, right? Because of the Lyrica and benzos still in the system working, right? So just to note that.
So Q, if you're getting some good signs like their breathing's regular again, but they're still unresponsive, what are we going to do? We're going to think they're okay, or we're going to not? No,
you're still going to stick with them. You call 000, okay? Very important to note that, because they'll have like a pulse oximeter, and what that is they'll take like how much oxygen is running through your blood and stuff like that. And very important to get those numbers, all right, and to objectively measure if they're breathing well and perfusing well with oxygen or not. So make sure, even with the naloxone, you've always called for help as well, all right? Never not call for help, all right? And make sure you tell them it's an overdose, not a heart attack, okay?
Cool. And we've got another question. It's got an obvious answer, but there's a little bit of a but, I think. Does naloxone work if it's not an opioid overdose?
Naloxone only works for opioids. It's specific for opioids. So opioid being heroin, fentanyl, codeine, tramadol groups, right? But why we do that even in the, let's just say that your friend Bob only uses benzos and he's overdosed, and why would you use naloxone? Just in case he's used opioids and it's a poly drug, all right? And you want to get rid of that opioid action, and that taking that edge off can help them breathe again, okay? So yes, it does not work. It does not work for benzo overdose, alcohol overdose, antipsychotic overdose, sedative antihistamine overdose, Lyrica overdose. It doesn't work for any of them except for opioid overdose. But because it's a polydrug climate, we always give naloxone just in case. Okay. And remember,
I've got a ripper of a question here, quite a technical one.
Yep.
And with Nixoid, the nasal version, how does it work if the person's not actually breathing? We're not talking about facial trauma. Nose is fine, but they're not breathing. Are they going to get it inside them?
Okay, so because it's not a cardiac arrest, right? We're not talking about your heart being stopped. It's just your breathing, right? There's still blood flowing through, all right? And your nose, this triangle here, anatomically has a really good vein system called a cavernous sinus. And when you blow the load, I'm gonna keep using that, sorry. Blow the load into your nose, that sinus system, those veins in your nasal cavity is still running around, right? And it will grab onto the naloxone dose because it's very concentrated in there and into the brain, okay? So there's a really good blood flow into the brain through your nose. That's why you use cocaine through insufflation, or you snort cocaine or snort drugs, because that's how it works. You're not really breathing in cocaine, right? You're not breathing into your lungs. You're actually breathing into your nasal cavity. And that's the same thing here for Nixoid, okay?
Yeah, I knew that, cavernous sinus. I've made a note of that. Folks, we're going to be wrapping up pretty soon. If you have any more questions, you better fire them through. But right now, we're going to move through to the quiz. We've got, I think, maybe 3 questions. Now, there are some great prizes here. If you're the first person through with the correct answer, I will read your name out loud. That's the extent of the prizes. So, Lily, maybe would you like to read out the question? And the first person to come through with the correct answer will get their name read out loud. Go, Lily.
What is a sign of an overdose? We've got unresponsiveness, moving and shaking, mumbling, or D, all of the above. Who have we got?
The answers are already coming in. So Diane, well done. You were the first through. Sangeeta gets second prize, and Desiree, I think it was, with third prize. Well done. This is yes, there are other signs, but the different kinds of things. You might be intoxicated. The overdose, the big thing is the unresponsiveness. Now let's go. Question number 2. I'll see if I can keep up with the chats and see who's winning.
So naloxone reverses the effects of which drug or drugs? We've got methamphetamine, benzodiazepines, opioids, or all of the above.
Man, they're quick, these people, but they're
Everyone
quick
should
as
get this one right. Come on.
the quickest was our good friend Kate from the city of Port Phillip. Well done, Kate. We'll have your prize in the mail, which is me writing your name down and sticking it in an envelope. Fantastic. We've got one more question to go.
So how do you prevent an overdose? A, don't mix drugs. B, get regular health checkups. C, try a small amount first. Or D, all of the above. You can see them.
Claudia, Emily, Bianca, Diane, Kate, Rhiannon, David, mate, Mav, well done, everyone. Oh, I think everyone got all of the above.
Everyone got all of the above. Awesome.
Well done.
Well done, everyone.
That ends the quiz. Lily, tell us about the fact sheets and where we can get more information.
Pennington Institute, I think where it's going to be dropped into the chat. We've created some overdose prevention educational fact sheets. So there's about 10 on our website, and there's a range of how to use ampules to chronoxide to Nixoid. So if you jump on there, there'll be also overdose prevention. There's a whole range of different things. What to say to pharmacists, what scripts for naloxone are going to look like. So yeah, jump on. We'll also send you these fact sheets as well. So it's just been dropped in now.
Fantastic. Another question just came through. Am I to assume then there are no antidotes for amphetamine overdose?
That's correct. No, not yet. There's yeah, I'm sure there's lots of trials going on, but there's nothing. There's only antidotes for opioids.
So yeah, amphetamine overdose is very varied. Okay, stimulus overdose, there's many different types. It can be like a mental thing, or it can be an organic damage, like a brain failure, like a heart attack, stroke, kidney failure, or it can be like psychosis. So it's very varied. There's not real like an antidote per se. Okay, yeah.
Unfortunately. We've got Rob from Shark. Tell us where families can go for help, Rob. My apologies.
Absolutely. Look, thank you, Patrick. No, it's been a fantastic evening, and it's really important. We're talking about stigma and the importance of getting support, and families are no different. And families and friends and everyone we're using as company are affected. So Family Direct Help really came out of that high point of overdoses in the late 90s. And families can often feel very isolated and alone. So we provide a range of services for families, and we're staffed by fantastic trained volunteers on our helpline. So we'll just drop in a link in there as well for that. So that's 1300 660 068. And check out our website. We have a lot of programs that are education. We also have support groups, which are a place where you can get education as well as support. And sadly, we have a need for a group which we call the Supper Club, which is a bereavement group for those who may have lost a loved one to overdose. And of course, that's a safe and confidential group, which is run by a grief counsellor, Fran Williamson, who's also during this week of Overdose Awareness Week is happy to take any calls as well. So that can be contacted through our helpline. So we have a lot of great programs. Check us out. We're also, because of COVID, doing everything on Zoom. So we're incredibly accessible, and we're just a phone call away from support. I think the most important thing for families is knowing that you're not alone and that you get really good support. So just wanted to put that out there.
People, get that number down. Shark is a very, very highly respected organisation in the drug and alcohol sector. 1300 660 068. Thank you very much, Rob. I'm so sorry that I lost track of you there. We're signing off. Send out your messages. We will see you next year. We need to do this training every year to remind ourselves about changes in the technology and just how to do the whole technique and to feel that wonderful sense of community. Remember, we are all someone's love. And remember, there is no power for change greater than a community discovering what it cares about. That's what we're all doing here today. Thank you, everyone. See you next year.